Hello and welcome. Thank you so much for joining me this evening. I'm so honored and privileged that you are here, whether you're doing this live or whether you're listening to the recorded version. Thank you for taking time and caring about sexual health. Tonight, we're going to be focusing on men, so men's sexual health in particular, people with penises, men, however you identify. We will be talking about penises, prostates, all that stuff this evening. So that will be our focus. Remember, you can join us on social media, all these different ways. That's for sure. So we are on Facebook, on YouTube, any of those ways are fine. Maybe you're here that way this evening, and welcome. And so we have our website. That's another great way to join. And you can actually see all the upcoming episodes. And there's a lot of things. And I will talk about that as we move along, because many of the things we're going to talk about, we're having more in-depth discussions about in the near future. So go to the website and you can find out more about upcoming episodes. But I'm just so glad that you're here this evening. As we get into this presentation and discussion, I want you to kind of get yourself in the right space and place with this. It's difficult. Each of us human beings are uniquely different, but we're intricately connected to other human beings in the world. But we often want to compare ourselves, which is a great source of suffering for most people. We also think oftentimes we feel like it should be better, we should be more, all those things. But it is what it is, and we are who we are, and we're dealing with the challenges we have. The goal here, the whole mission of this podcast is really just to empower you and enlighten you with the facts you need to improve your sexual health, to deepen intimacy with your partner, and to build more fulfilling relationships. That's all we're doing every week here, is trying to work on some of that. More love in your life. And I hope that you have more love in your life. That is my hope and prayer for you. So we're going to dive into our conversation this evening. I will be talking because I have been working with men, people with penises, men who identify as men or not. I have been working with men and women for about 30 years, have worked with thousands of patients. And so this is something that I have done in my clinic for many, many years. And so I'm going to share with you, based on the science, a little bit about men's sexual health, which sometimes can be challenging. Women do a great job. It's amazing. They do such a good job of advocating with their health. And speaking as a male myself, oftentimes I am not the best advocate for my health. And oftentimes I don't seek help when I should be seeking help. I always think it'll get better. It'll be fine. It'll all be good. But so I think it really is important for us to know about male sexual health. And so we're going to talk about that some this evening. I can tell you, I don't know what it's like where you are, but it is really, really cold here in Chicago. We have been in single digits and wind chills well below zero all day, and it's been very cold. So I hope some of this warms you up this evening, and you will have a chance later to ask questions, and we'll tell you, you can do that in the comment section, but we'll show you how to do that when we get to that section. And Vic will join me, because Vic has worked with lots and lots of men with these issues too. And he will come on and feed me questions and also talk about these issues as well, because we both have done this work for many, many years. So let's jump into the presentation. All right. So first off, we're going to kind of dispel some myths. We already talked about tonight, we're talking about men's sexual health. Here's the myth we're going to go after this evening. All men have great erections and are great lovers. That sounds wonderful, and that would be fantastic. And I'm sure men would love for that to be the truest thing in the world. But it's not always the case. And so we're going to talk some about that. All right. First off, I told you, I kind of alluded to, I'm not the greatest person to go in and deal with some of my health issues. I always think it'll get better on its own, and I'm hesitant to do that. Excuse me. So when we look at men in healthcare, mostly men only sought healthcare for school and sports physicals through high school and college. So we're not used to really going in, being examined, dealing with healthcare issues. Men tend to disengage from healthcare systems after they graduate from college. And so men are mostly only seeking medical care when they have injuries, illnesses, things like that, not necessarily for health maintenance, but more for health problems. So when they have issues around sexual dysfunction, men want I always say the men who come to my clinic want something that I really can't give you. What they really want is they think it, and with the least provocation, they get hard, they're able to have sex, no worries. None of the treatments or none of the different things we can do give you exactly that. So I feel like what patients really seek, the men who come in and want to deal with these issues, what they really are seeking is, I think it happens. And unfortunately, I don't have that magic anything that does that, nor does anyone else. And I wish I had that magic thing. And if I had it, I would give it to every patient that I see, certainly. But it's really challenging because these issues can make you feel vulnerable. And they're surrounded in shame and secrecy because men don't want to talk about this. When I was running my prostate cancer group last week, we were talking a lot about this. And I think men are really hesitant to talk about it because there shouldn't be shame, but there is. You look at the world and you think remember the myth, everybody has great erections, everybody's a great lover, nobody has any problems. But you're going to see from the research, many of the men you know do have problems, and it is not uncommon. It is the number one thing that brings men into the sexual health clinic is erectile dysfunction. And we're going to talk a lot about that more specifically this evening because it is an issue that is quite common. Also, they want it quick, they want it easy, they want it anonymous. They're feeling vulnerable, so they're just trying to how can I find a solution? And I don't really want to have to deal with I don't want to have to necessarily talk about it too much. And that can really be challenging. So they go to the internet, Dr. Google, right? And so that is a common place people go. Internet medical information and care. There's a wide range of information. The good news is there's a lot of stuff on there. You can access medical information you can find online diagnoses and prescriptions you can get online. You can go to chat rooms, websites, online support groups, so many things, which is in many ways a very positive thing. And so when you look out there, though, there's so much information. And how do you determine what's really good scientific-based information versus what's not? It's easy to access. It maintains your confidentiality. It enables a sense of autonomy. It makes you feel like you can do it yourself and it's not a big deal. And there's tons of information updated all the time. This is all a very positive thing, but it can also be challenging because you don't have somebody to guide you through, to help you navigate your way through what you're looking at. And you don't have that individualized care that is given to you by an actual healthcare provider. But I do think that as an adjunct, as something added on to the things you're doing, it can be really helpful. But you do have to be careful. You want to go to trusted websites, trusted places, institutions that have good reputations, people who are certified in their specialty, like urology is what I'm certified in. And so it's important. So, and also there's a lot of people out there who want your money. So be so careful because the herbal industry, remember the FDA does not really oversee the herbal industry, so they can say or do whatever they want if it's an herb. And so often the scientific rigor and scientific information is not there on many of those things. I have found many of those things don't work at all, and some of them are dangerous. I've seen people end up in the emergency room from things they got in a gas station. So you really do have to be really, really careful of what you're doing. So be careful the sources of where you get things. There's also a cosmetic industry, a aging industry that has a lot of different things, all of which are not necessarily FDA approved, but and don't have the science and rigor to really support them. So I really think you have to be careful and go to trusted people to find what you really need. I've seen people spend lots and lots of money on things that just don't work. And we certainly don't want you to end up in the emergency room with a real problem because you used something that was a little bit dangerous. And sometimes medical emergencies do occur around this. So when we think about, well, how does an erection occur? What is it all about? When a man thinks psychogenic thoughts or has tactile sensation on his penis or both, that is all put together in the frontal lobe of the brain. The message goes down the spine to the peripheral nerves, which come off the tailbone. And so when we think about the tailbone back there, comes off the tailbone, wraps around the prostate, bundle on the right, bundle on the left, and goes towards the penis. When the nerves for erections, when the nervous signals get down to the penis, they cause the smooth muscle to relax. The blood vessels fill or engorge with blood. You get 7 or 8 times more blood in your penis when it gets hard. And so as that blood fills, it squeezes the superficial veins closed and you got an erection. So what do you need to get an erection? You need nervous conduction between brain and penis back and forth and blood flow to fill or engorge the penis. Inside the penis, you see there's chambers, one on each side, one on the bottom. The paired corpora cavernosa, which are full of blood vessels surrounded by smooth muscle, and the corpora spongiosum, that's where the urethra that you urinate through. These cylinders are full of blood vessels and smooth muscle. So the smooth muscle relaxes, the blood vessels fill, engorge, the penis gets hard. As they fill to capacity, they squeeze closed the superficial veins and the blood is in the penis and you have an erection. So that's how a normal erection occurs. Blood flow and nervous conduction are the key components, and they are really, really important. So if you have any issues with blood flow or nervous conduction, you're probably going to have issues with this. So what is erectile dysfunction? Because I said that is the number one issue that brings men into the clinic, and that's what we're going to mostly focus on this evening, but we will hit on other men's sexual health things as well. We'll talk a little bit about the prostate and ejaculation and things, but we're mostly going to talk about erectile dysfunction because that is the number one problem that brings men to clinic. And it's just the consistent or recurrent inability to attain, to get, or keep an erection sufficient for sexual performance or satisfaction. So you're having difficulty getting or keeping those erections. And so that is what erectile dysfunction is. Is it common? Well, study after study shows you see 18.4%. So about 1 in 5 men in their lifetime will have erectile dysfunction. In younger men in their 20s or so, about 5% or so, which is not nearly as much. But by the time you get to 60, about half of men have erectile dysfunction, 70 about 70%, 80 about 80%, and so on. So having erectile dysfunction is a very, very common problem, especially as you get older. Is it because you're getting older? Part of it can be due to the aging process, but more importantly, it has to do with comorbid or medical conditions that occur as you get older. What happens? Cardiovascular disease. In America, hugely hyperlipidemia, hypercholesterolemia, so high cholesterol, lipid issues, cardiovascular, coronary artery disease, diabetes. All these things are much more common as you get older. Diabetes affects blood flow and nervous conduction. That's why as you'll see, most men with diabetes have erectile dysfunction. High blood pressure, coronary artery disease. We're going to talk about how all of that impacts blood flow, nervous conduction, and erections. Healthy heart equals healthy erections. But problems with the cardiovascular system and heart means problems with erections typically. So we're going to talk more about that, but you can see diabetes, all those comorbidities, medical issues, DM's diabetes mellitus, HTN is hypertension, hyperlipidemia, that's cholesterol, triglycerides, lipids, heart disease, lower urinary tract symptoms that come along with enlarged prostate, and depression. Many, many things can occur. And so it's really important to remember lots of things can cause problems with erectile dysfunction. And it is a common problem. By the time you're in your 60s and 70s, half to 70% of your friends and cohort in your age group have erectile dysfunction. When we think about cardiovascular disease, erectile dysfunction is actually an independent predictor of overall cardiovascular health and cardiovascular disease. And you can see that the risks go up when you have cardiovascular disease, coronary heart disease, all these different heart and cardiovascular issues. So what is cardiovascular? Cardio is the heart, vascular is the blood vessels. And so when you have problems with the heart or blood flow, myocardial infarction is a heart attack. When you have these problems, stroke, it often can cause erectile dysfunction. But actually, when you have erectile dysfunction, there's study after study that shows you could have a cardiovascular event, a heart attack or stroke, usually within the next 3 to 7 years of having consistent erectile dysfunction that's not explained by something. Like, for example, if you had a prostate surgery that caused it, that's different. But if there's not a distinct reason you started having erectile dysfunction, and it maybe even came on a little bit slower, and then it could be an indicator or a harbinger that you could be headed towards a cardiovascular event. And nobody wants that. So you want to get really healthy and seek health to make sure you are healthy if you're having consistent erectile dysfunction, because it can be a sign of underlying cardiovascular issues, heart or blood flow issues. The Princeton 3 consensus recommendation says that you should have a comprehensive cardiovascular workup, and including for erectile dysfunction. So they have to kind of determine, is it organic in nature, or is it psychogenic? Often it's both. But so if it's organic, it's considered a higher risk. If you're having true problems with erectile dysfunction that are not just psychogenic, that's where it can be a indicator of underlying cardiovascular disease. Okay, and remember, research shows that a man with erectile dysfunction may progress to a cardiovascular event, a heart attack or stroke, in 2 to 5 years after the erectile dysfunction diagnosis, especially, again, when it can't be explained by you had a surgery or radiation that caused it or something else that occurred that caused your erectile dysfunction. We look at exercise capacity, and we use that to categorize you as a low, an intermediate, or a high risk. And then so all that assessment is really important, so we make sure you don't have a cardiovascular event. So if you can tolerate going up and down a set of about 15 steps or so without shortness of breath or chest pain, usually you can handle the low impact aerobic activity of sex as well. But seek medical care and figure out exactly what's going on if you have consistent issues with erectile dysfunction, or certainly if you have chest pain or shortness of breath when you're going up a set or two of stairs, equating to about 15 to 20 stairs total. Low testosterone actually sometimes, in particular, can cause increased mortality rates, but not always. And so that's something else we may want to check. Testosterone mostly gives you your desire. It has a very small role with erections, but a big role with desire. So that's why we usually check that too. But a lot of men think their erectile dysfunction is caused by testosterone or endocrine issues, and that's only 5% or less. What causes it? Remember what we said. Blood flow problems. So cardiovascular disease, anything that affects blood flow, high blood pressure, and also nervous conduction. Number 1 is blood flow. Number 2 is nervous conduction problems. So you have chronic low back problems, or you had a stroke, or you had something that affects the communication between your brain and penis, and it's not getting through. Or you had a prostate surgery, and they had to pull the nerves off your prostate to get it out. So now the nerves become inflamed and they're not working properly. They told you they spared the nerves, and they did, but the nerves are traumatized and they're inflamed and they're not working. Or you had radiation to the area. Lots of different things can affect nerve conduction as well. So anything that affects blood flow or nerve conduction are the number 1 underlying causes of erectile dysfunction. So what about diabetes? Well, you can see most men with diabetes have erectile dysfunction. The prevalence of erectile dysfunction in diabetics overall was a little over half of the men after adjusting for different biases and things like that. Another cross-sectional study showed, again, very similar, about 51.3%, 52.5% in the other study. So very consistent things that say men with diabetes, because it affects blood flow and nervous conduction, it can also affect erections and cause erectile dysfunction. Again, more studies that talk about how it can affect how diabetes has an impact on erectile dysfunction. But there's other things to think about. And if you have diabetes, what are some of the predictors? Higher levels of depression and an increased hemoglobin A1C, especially if it were 8% or higher. Remember, it's supposed to be about 5.5, 6 in that range. To be in the normal range is lower than 5.5 or 6, depending on your age and what you're looking at. But if it's greater than 8, that's a predictor, if you have diabetes, that you'll probably have erectile dysfunction. If you're on insulin, you're 3 times more likely to have erectile dysfunction than someone who is not insulin dependent with their diabetes. But age, smoking, high cholesterol, we talked about all those, and neuropathy, that's nerve damage, so blood flow, nerve damage, all these things. We're going to talk more about depression. When you're depressed or you're anxious, you don't necessarily want to have sex. Depression has been linked to and identified as a cause of erectile dysfunction. Anxiety, when you become anxious, anxiety is adrenaline. Adrenaline is part of fight or flight. If you go into fight or flight, the blood's going to move to your brain. It's going to move to your muscles. It's going to move to places for fight or flight. It's going to move out of your penis. If you start thinking, oh my God, is it hard? What's it doing? What's she think? What? You don't even have to look down. You are going to lose your erection because anxiety is adrenaline. Adrenaline is part of fight or flight, and it causes a physiologic response, and you lose your erection. So anxiety, depression have been linked to erectile dysfunction. Smoking. Nicotine causes increased sympathetic tone. It causes those blood vessels to kind of squeeze in the penile smooth musculature. It kind of squeezes around the blood vessels, and so it causes vasoconstriction, decreased blood flow. And remember, an erection is all about blood flow. So smoking almost doubled the chance of having erectile dysfunction. In Europe, they had this ad at one point, which I thought was brilliant, with these guys standing against the wall smoking a cigarette. And as the woman walked by, the cigarette goes whoop and drops like that. Even some of my patients have said, why doesn't the cigarette give you a warning? It says you can get cancer, but it doesn't tell you it can cause erectile dysfunction. When you're young and healthy, it doesn't matter so much. But as you get older, remember, smoking has multiple insults to erectile dysfunction and sexual function. It decreases sensation on your genitalia. It decreases, NO means nitric oxide synthesis. So when you take pills like sildenafil, Viagra, tadalafil, Cialis, vardenafil, avanafil, they're all in the same drug category. They block an enzyme that inhibits the chemicals in your penis like nitric oxide, cyclic GMP, that help make you hard. So now if we block the enzyme that inhibits the chemicals, it's like math. If we inhibit the inhibitor, now we have more chemicals to help you get hard when you get excited and only when you get excited. So that's important. But nicotine does the opposite. It decreases nitric oxide synthesis, which is essential for erections. And so 3 insults: decreased sensation on the penis, decreased nitric oxide synthesis, and it also causes vasoconstriction. So it majorly can affect blood flow and erections. So yes, smoking is detrimental to your erections. Sleep is super important because while you sleep, you build testosterone. We said testosterone is not that important to erectile dysfunction, but it's still important to desire, a little important with erections, a little important with climax. You build it while you sleep. That's why we want it within 2 hours of getting up. We want to test it because that's when you build up your testosterone, and we want to see if it reaches where it should be at its highest when you first get up, within an hour or 2 of rising on an empty stomach, fasting. But also, even more important, while you sleep, your penis literally works out. It goes up and down while you sleep. From the day you're born till it's not working right, your penis literally works out to keep itself in shape while you sleep. So if people tell you, if you don't use it, you'll lose it. If your penis is working properly, it will go up and down at night while you sleep, and it doesn't care whether you ever use it. It will continue to function if it's doing that. Normal function includes that penis going up and down, typically 4 to 6 times a night. The penis is erect, so often 2 hours out of 24 hours during deep REM sleep. So while you sleep, your penis keeps itself in shape. Super important. When it stops doing that, you don't have that muscle activity inside. You don't have that blood flow happening, and can lead to further erectile dysfunction and worsening of symptoms. So sexual health is really dependent on sleep, especially deep, good sleep. Sleep apnea is linked to sexual dysfunction, erectile dysfunction, and low testosterone. Treating the sleep apnea or the sleep disorders is important to overall sexual health. Insomnia, all kinds of issues can affect sleep. As we get older, sleep just isn't as good as it used to be, but sleep is very important to sexual health, definitely, in several ways. We can talk more about it if you have questions. So there's lots of different medicines that can affect, but these aren't all usually the main things, usually the medical problems. If you have uncontrolled high blood pressure, that blood rushing through those blood vessels will lead to erectile dysfunction, period. But some of the antihypertensives we use to control the blood pressure also can have a negative effect on erections. So you got to talk to your doctor. Controlling the blood pressure is the most important thing, but you need to talk to them about the different medications that you're taking and can they be problematic if you're struggling. So if you went on a medicine and you start struggling more, probably that medicine could potentially be affecting you negatively in terms of your erections, and some do. Antihypertensives, antidepressants often cause delay in climax, but sometimes can cause erectile dysfunction, decreased sex drive and libido, different things. But remember, sometimes treating the depression can improve your libido and your erections, because depression can adversely affect erections. So again, it's a tricky wicket, and working with your healthcare team is really important with this. Prostate medication, some of the anti-androgens that are used for prostate cancer, and some of the benign prostatic hypertrophy or hyperplasia, enlargement of the prostate medications, can negatively impact sexual function. Even histamine 2 blockers that are for your stomach or different things like that can cause erectile dysfunction sometimes. Antihistamines and cold and allergy medicines like pseudoephedrine and things can also affect. So it's just sitting down with your provider to understand which things might be a problem. And sometimes you discover them on your own because you went on it and it became a problem. So medicines can sometimes be a little bit of the issue. We have lots of different ways to treat erectile dysfunction, and we will actually have an episode on, for example, the vacuum device in the future, some of these different treatments, but we will explore further into this. But I just wanted to at least touch on that we do have treatments for erectile dysfunction. Lifestyle counseling can be really important. Understanding how your penis works and what will help it work better. Making sure you're getting proper sleep. Cardiovascular exercise. If it's good for your heart in terms of a low fat, low cholesterol, low carb, high fiber, plant-based diet, it's often good for blood flow and erectile function. Cardiovascular, you need about 3 hours a week of cardiovascular exercise. Your body was designed for it, and that can be helpful with getting the blood moving and with sexual health, including erectile health. Psychological counseling, because we talked about depression and anxiety, cognitive behavior therapies, all these things to address some of the issues, because even when it's a physiologic thing, even when it's caused by diabetes, high blood pressure, whatever, it can mess with your mind. It makes you anxious because you've had trouble before. You're worried about having trouble this time. So usually if you have most men with erectile dysfunction, there's a physiologic underlying reason, but usually that leads to a little bit of anxiety and some psychological issues as well. And so usually it's a combination of both. So dealing with both can be really helpful. We talked about how hormones may be important, especially testosterone, which gives men and women mostly their sex drive, not as much for erectile function. It's not really considered a direct treatment for erectile dysfunction. It's more for libido or sex drive. really the things that are treatments for erectile dysfunction have to do with blood flow and nerve and getting the blood down there. So the vacuum pump, where you literally force more blood into your penis with the vacuum device. It's a medical device that's been approved. And that blood, once it fills the penis, you place a band at the base of your penis that comes off the edge of that device. And we'll show you all this when we talk about this in a couple weeks. But it forces more blood in with the vacuum. So let's say you get a partial erection, it makes you hard enough. And then the device, your penis is in the device. When you push the ring off the edge of it, it goes to the base of your penis, and then you can get your penis out of there and into your partner. So it works in about 90% of patients, but it's cumbersome, it's awkward. All these things have good and bad. The best thing that men really want is they think it happens. And again, everything we do for treatments, there are positives and negatives, things to think. Is it right for me? Medicines, we have pills. Oftentimes we have to think about timing with the pills because the pills peak, most of them, in about an hour to an hour and a half. And some of them have to be taken on more of an empty stomach than others. But there's a lot of little pieces that you need to understand when you're on these things to help you get the very best effect from them. They don't work in everybody. Pills work in approximately 70% of patients. So Avanafil, sildenafil, which is Viagra, tadalafil, which is Cialis, vardenafil. These different medicines are, like I said, designed. We block this enzyme that inhibits the chemicals in your penis that make you hard. So you have to time it. You have to work with it a little bit. They don't work for everybody. They can be helpful. Some people have side effects, lots of things to think about. And we can talk more about that with questions, and we will talk about it more in other episodes as well. There are shots that you can give yourself directly in the penis that cause the smooth muscle to relax and the blood vessels to fill. So you want to really work with that as well. And again, here we talk about the scientifically based things that have double-blind studies, things that can be really helpful. But all of them have good and bad, so a lot to think about. So we have pills, we have shots. We used to have a pellet, but that's no longer available. That's another pharmacological agent. And then we have penile implant surgery, where they replace the mechanics of your penis, put cylinders in your penis, a pump in your scrotum, a reservoir in your abdomen. When you pump in your scrotum, it moves the fluid out of the resting chambers into the penis chambers and makes you hard. When you hit the release, the fluid goes out of the penis chambers and back in the resting chamber in your abdomen. All of this is put in internally, and this is a surgery. That's the inflatable penile implant, the more popular one. There's also a malleable version that you just bend up when you want to have sex. It's always semi-rigid. So there are surgeries as well. The surgeries are penile implant surgeries, and those are the things that have science behind them that can be helpful. There's a lot of stuff out there that doesn't have science. If you're looking at herbal things, I recommend that you look at Mark Moyad's. He's got an A to Z book on herbals, and he can tell you the pros, the cons, the bottom line on them. Most of them don't have the science to completely support them and aren't always helpful. Some can be a little dangerous. We used to use something called yohimbine that came from the bark of a tree that ultimately caused cardiovascular issues, and we had to stop using it. So be careful. Lifestyle management is super important. I talked earlier about diet, exercise, weight control. We can talk more about it if you want to talk more about it. But Mark Moyad, who actually has a chair to say, what besides pills and medical and surgical things work in urology? He says nothing works like diet, exercise, and weight control to help with erectile dysfunction. Study after study shows that triad of diet, exercise, and weight control are the bomb for men when it comes to erectile function. So if you really want to work on your erections, and you can, because sometimes it's difficult with your health issues, then diet, exercise, and weight control. Low fat, low cholesterol, low carb, high fiber, plant-based diet. About 3 hours a week, 150 to 200 minutes a week of cardio, and really getting healthy and getting that BMI, that body mass index, and that weight at a healthy level for your height. So I can't say enough about how important lifestyle management is and what an effect it can have on your sexual function. I want to talk briefly about two other things before we go into questions, and one of them is So you can have delayed ejaculation where it's difficult to climax, which can be a more difficult thing to treat. But you can also have premature ejaculation where it happens too quickly, usually within a minute of vaginal penetration or partner penetration or whatever you're trying to do. It usually can't be controlled, and it causes personal distress and upset. It occurs in about 20 to 75% of men, more common in young men. So why would that be? If you're partnered with a woman, Masters and Johnson proved women take 4 times longer to climax than men do. So in general, if you're trying to time your climax with a woman in particular, they take 4 times longer to reach their climax because the clitoris is more internal. And so their stimulation is a little different, and it can take longer and be more work for them to reach their climax. These are generalizations. But in general, women climax 4 times slower than men do. And so premature ejaculation can be a common complaint, and there are treatments, and we will have someone coming on to talk about this in the future, and we'll go much more in depth with how we treat that. And so we do it by decreasing sensation on the penis and then and a few other things. And so we'll talk more about that when we do that episode, but we can in question and answers. Lastly, I want to touch just briefly on the prostate before we finish up, because prostate health is super important too. So right below your bladder, the urethra, which carries the urine out of your bladder, goes through the prostate, which sits right at the bladder base. It's a small structure that sits at the bladder neck, bladder base, and the urethra that carries the urine out of your bladder goes right through the middle of that prostate. And so that prostate is where the fluid comes together, the ejaculate, where it all comes together. Not just the sperm, but the semen, all the fluid that nourishes the sperm and keeps it healthy. It all comes together there, and then it's propelled out of your body. So they can do screening and checks. They usually start typically around age 40 or 50. You can get a baseline, I think, can be very helpful at age 40. That's when my doctor did a baseline on me, and I think it can be very important. And then they're checking to see, is they have the right consistency. They do 2 things. They do a blood test, which is a prostate-specific antigen, PSA blood test, and they do a digital rectal exam. The combination of those 2 are considered a screen for prostate cancer, prostatitis, benign enlargement. Prostatitis is an inflammation or infection of the prostate and is more common in younger men. As you get older, if you live long enough in the later decades, you will have benign enlargement. Your prostate will, if you live long enough, it will squeeze in on your urethra and cause urinary issues with urinary frequency. You can get frequency, urgency, incomplete emptying. Your stream isn't strong like it used to be. You can't write your name in the snow like you used to. Your stream is affected. So it's squeezing, even if it's not getting bigger outward, it squeezes in on that urethra. And by the time it starts in your 40s and 50s, but can worsen in your 60s, 70s, and 80s. And there are medications and there are treatments for it, including surgeries and other procedures that can help with it. Then there's prostate cancer, which is actually malignancy of the prostate. And remember, that is the most common non-skin cancer in men. So I run a prostate cancer group. I wrote a book for prostate cancer patients, and I see a lot of prostate cancer patients because when they're treated, often the treatments can affect sexual function. Of course, if the prostate's removed or irradiated, that's going to affect ejaculation and semen and things like that coming out of your body. Also, the nerves for erections are right down there. So if they're radiated or you have surgery, as I said earlier, often erectile dysfunction will be an issue. So we have 3 things that can happen with the prostate: an inflammation or an infection called prostatitis, benign enlargement, where the prostate just squeezes in, especially on the urethra. Sometimes it will get big growing outward too, but how big it gets outward doesn't necessarily equate to how much it pushes in on the urethra. Sometimes it's still small outward, but it's squeezing the heck out of that urethra and causing urinary symptoms. That's why we call it BPH, benign prostatic hyperplasia or hypertrophy, and lower urinary tract symptoms. They go hand in hand. And then prostate cancer. We will talk more about this in future episodes because we can do whole segments on that for sure. But men's health is very important. Sexual health in terms of blood flow and erections, as well as prostate health. So in summary, men's health impacts sexual health. So how healthy you are has a major impact on your erections and your sexual health. Sexual health encompasses your mind, your body, your spirit. So get healthy. We want our mind, body, and spirit to be healthy. Overall health or heart health equals sexual health. And so, in summary, we just want you to remember, take care of your body. What could be more important than your health? I think that's number one. Number two is what else could be more important than your relationships, the people in your life and your relationships with other people. So first and foremost, your overall health. And then secondly, your relationships and the love that you have in your life with other people. So that's why we're here talking about this with you today. And thank you so much for joining me. We will take questions. And so, Vic, thanks for coming on, and
Yeah.
let's talk a little bit more about this. And so,
Yeah. Great review, I think, of all the issues that, things that can cause problems with erections. And as a lot of times, I'm sure you've heard this before, patients will come in and say, well, why is this not working? I always say it's more of a miracle that it does work. All the things that have to go right, it's not surprising that things can go wrong. So I think that was a really good review. We do have a lot of questions here, so I'm going to go right to the questions, I think. A lot of people said thanks or hi from different areas, Florida, Milwaukee. Nice to have you in the house.
definitely.
A couple things here. Let's see, Arizona. Well, here's a question from Peter. In your experience, have you seen many with finasteride-induced ED, and how have you treated it?
So, it certainly is not the main thing that brings men into my clinic, and I don't see it that often, but I've absolutely seen it. So finasteride can be used to treat benign prostatic hyperplasia or enlargement, but it also is used for propecia. And so I have seen both young men on it for propecia, and I have seen, and the evidence does support that it can happen. It is not one of the main things that causes erectile dysfunction or brings men in. But I definitely have men who don't have any other risk factor, nothing else when we do their history, their physical that fits, except that they are on finasteride. And so, and sometimes if you've been on finasteride for a while, even when you come off it, it won't, the effects still can linger. And you can also get, there's a syndrome that can happen with finasteride. It's not very common, but it can happen. So it's a great medicine to help shrink the prostate with some men who really need help with BPH and don't want to do surgeries and different things like that. It's also, some men are very concerned, and propecia can be a big problem. And so it's in that medicine. But absolutely, we do sometimes see it. The rates are not super high. Sometimes it causes absolutely none of those problems in men who have been on it for years. Everybody is different, but have I seen it? Yes, in young and older men. Vic, have you seen that in some of your patients as well?
Yeah, absolutely. Not very common, as you said, but it does occur, definitely.
Mm-hmm. So, especially in my younger men, when they're on it and they're healthy, everything else seems fine. I'll see if they're willing to come off of it for hair loss or whatever, and sometimes we'll see it turn around. But it's definitely something to look at with the finasteride. But again, some people completely safely take it and have no sexual dysfunction from it. Most people don't, but some
Right.
people do.
Absolutely. I just wanted to say hi to our viewers on X. We have some viewers coming in from X. Glad to have you on board. Unfortunately, we don't get our comments coming through on X. We do see them from the YouTube channel and Facebook, and from of course, our StreamYard studios. So if you're interested in asking questions, but you're watching on X, you have to use one of those other formats. All right. Now I've got an interesting one that came up here from Bradley Short on YouTube. Offering some, I never heard of these Kiandra berries, 50 a day for 60 days. And it's going to make that erection no issue, no problem with your erections. You did mention something about these herbal treatments and some of those things out there, over the counter therapies, really not always being the best. Can you comment a little bit about that?
Well, as I said, I think people think, well, it's natural. Well, medicines come from things often from plants and different things. And so just because it's natural or it's something that occurs in the world, remember, there's poisonous things in the world too. So you want to be careful. Often they'll even use the lingo, oh, we have scientific studies. But like I said, I was reading about one particular one that Mark Moyed looked at, and it said there were 5 studies, and there weren't. There were absolutely no studies. So I think looking to see, is there real science behind it for safety and efficacy? Remember, first off, does it work is important. That's efficacy. And is it safe? Yeah. I talked even about, you remember Yohimbine, how we used it, Vic, and that it was
some of the side effects.
It had science to support it, but ultimately it had cardiovascular side effects, and it had to be abandoned because of those adverse effects. So you just want to be very careful about herbal things, and you want to look at them carefully. There is a little bit of data on Korean red ginseng or Panax ginseng. You can find even meta-analysis and things about that to see what the studies are in conjunction with erectile dysfunction. There's a little bit out there on L-arginine and L-cysteine. Those are a few of the things that you can find some science to support, but much of the stuff is not supported. And again, I really like Mark Moyed's book and sources for that, to see what does he say about it, how did he look at the evidence, if you don't want to look at the evidence yourself. But be careful is what I'd say. I take a vitamin. I am not against supplements. I just don't want you to spend. I had a man who walked in, he was shaking. He had this bottle. He was 80. And he goes, they said I'll live longer because this is going to help me with my erections. It's going to make you longer, bigger, harder, whatever. They can claim whatever they want. If it made you longer, I mean, honestly, most men on the planet would be on it. The efficacy is often not proven and can be a problem, and sometimes safety too. But there are a few things that have some science to support them. Not a lot, but a few things.
All right. We did another question from Peter. What's your opinion on shockwave therapy for ED?
Oh, Vic, you probably recall I did a whole talk on this because this is very popular. I do think there is that as an adjunct therapy, along with other things, that it does have some proven benefit from the studies in men with mild erectile dysfunction. The men who walk in my office have significant erectile dysfunction, and so the pills are no longer working. The shockwave seems to work best for the men who are pill responders, to help them continue to be pill responders, and also to help them respond maybe a little better to the pills when they're on the borderline. Mm-hmm. But if you are no longer responding to oral agents like sildenafil, Viagra, tadalafil, Cialis, vardenafil, the shockwave, I have not found evidence in the science nor any patients who have found that to be helpful with men with significant erectile dysfunction. So I think it plays a role along with pills, along with the vacuum, along with other things potentially in the future. Remember, it is not FDA approved. It has not been, even though there is a fair amount of data, the science has not yet qualified it to be an approved treatment. So it will not be covered by insurance, and it could cost. Sometimes some urology clinics will do it as an adjunct, reasonable, but I have seen patients easily spend $3,000 to $15,000 on it, and I've had multiple patients who have tried it, and I haven't had a patient who actually came back and said it resolved their erectile dysfunction or fixed it. But remember, I see people with significant erectile dysfunction. I have great hopes for it in the future to be used along with other things, especially they've started a few studies with men with prostate cancer. But at this point, I really hate for you to spend all the money on it when it really does, especially if you have significant erectile dysfunction. You're not responding to pills, you're having difficulty. I would say don't spend your money on it, because you will have to spend your money, especially at some of the cosmetic clinics, because it is multiple sessions, and the sessions can be a couple thousand. By the time you're done, it could cost you. It's not unusual, $5,000 to $10,000, but in the right urology clinic with people who are using it adjunctly along with things and giving you hopefully a decent price to use it along with the other treatments that they're giving you. I think with the right, and it has to be done with the right equipment, because a lot of times the places who do it, who aren't urology clinics, don't use the equipment that's actually used in the studies, or the home equipment. It uses something that is not the same kind of sound wave and doesn't work the same. So it's low intensity shockwave therapy. So it's a different kind of shock therapy. So you got to be careful. The protocols have not been shown to be exact yet. They're still working on it. But I do think in the future, it might have a role. Is it going to be the solution for the men who other things aren't working? It's not been so far. Men with prostate cancer who have been treated, as well as men with ED from other reasons, it has not proven that so far. For men with significant, erectile dysfunction. But it has shown benefit for men with mild to moderate erectile dysfunction who are pill responders and things like that. So I'm hopeful.
Yeah. And you and I have treated a lot of patients that have severe problems. I mean, you just can't hand them a Viagra and everything's going to be fixed. But with all the options available, things like vacuum devices and the injection for erections that we are able to give, we're able to kind of capture a large number of patients that can benefit from these treatments and get back to having a normal erection.
Right. So and then also, even you don't need an erection to bring your partner pleasure or orgasm and most men, if it's a blood flow problem, they can have an orgasm with or without a full erection. So you can also enjoy non-penetrative outer course type things as well. So there are solutions. I still understand that for you in particular out there, it may be like, but I really do like intercourse and it's very frustrating, and it can absolutely be all that. So I'd like to end our session by reminding you, I think it's so important to know that you are so much more than these problems. You are so much more than erections or your penis. And so that can be hard to know or believe when you're going through it, and your struggles are real, and your frustrations are real, and they're valid. So work with a team to help you come to a better place in terms of your overall health, your sexual health, and of course, with your erections and everything else. So work with a team here too, because this is important, because it does. One of the patients in my prostate cancer group last Thursday was really articulating well how frustrating it is and how I don't want it to affect me this greatly, but it is affecting me. It really can be devastating for some men not. But Vic, we've had those patients that are very, very frustrated and upset about these problems with ejaculation, with erections. It's a really challenging issue for some men. If it's not for you, and it's not a frustrating thing, that's great. And you found another way to enjoy things, kudos to you, and that's awesome. If you are really frustrated, get the help you need from the mental health people, from the physical people, to move forward, to have overall health, to have relationship health, all of that.
And there's been patients that didn't want to have treatment out of the fear of losing their erection. Prostate cancer therapies can have influence your erection, your ability to get an erection, and they'll say, well, I think I'd rather not have the therapy. And you got to remember, I always tell them, dead people don't have erections. So
that is
take
true.
Care of yourself first.
And in my study and other studies, people do have treatment regret. But the thing that's difficult is when you have treatment regret, you also don't know what it might have been like to die from prostate cancer too. Yeah. It's hard to know. It's still real. It's still real. And it's a valid thing that this can impact people so much. And I think it's really important that your doctor know, if you're having prostate surgery or anything like that, that they know how important sexual function is to you, or and know about how that is within your life, because for you in particular, you need to think about that when you're going through these treatments that could negatively impact sexual function, like a prostate removal, a prostatectomy, or a radiation of the prostate, which can affect the nerves for erections. It's
Absolutely.
really important. And be informed before you go in. Don't look at statistics. Most men who have these treatments afterwards, after surgery, when you ask the men, do you have problems with erections? We're looking at 70-80% of men will say, yes, I'm struggling with erections after prostate cancer surgery or treatments. So go to the studies that show you what men say directly about it and be informed so you know ahead of time and you're not broadsided by that, or because that can be devastating too. You've seen it, Vic, with your patients as well.
Absolutely. Absolutely. Well, it's been a great discussion, Jeff. I'm going to bring in a little commercial for next week's show. Join us next week.
Dr. Jeff welcomes renowned couple and sex therapist Barry McCarthy, PhD, to explore the fascinating dynamics of relationships and sexual desire. Dr. McCarthy and his wife Emily authored the book Rekindling Desire. From understanding the natural ebb and flow of intimacy to addressing mismatched libidos and societal expectations, this episode offers insights into one of the most common challenges couples face. Learn how emotional connection, communication, and practical strategies can reignite passion and deepen intimacy, helping you build a stronger, more fulfilling relationship.
Excellent. Well, thank you so much for joining us this evening. We really appreciate you being here. And just know you can be healthier, you can be better, and hopefully this will help you along your journey. Thanks so much.
Absolutely. See you next week.